Hi everyone, and welcome to Module 6. This video will be overviewing the materials this week related to what I'm calling therapeutic dynamics, including responding to safety concerns, negotiating transference and countertransference, and also vicarious traumatization. When working in the mental health field, and definitely with survivors, as clinicians we expect to deal with suicidality. Suicidality refers to suicidal thoughts, suicidal behavior, suicide attempts, and actual suicide. As clinicians, we need to learn to distinguish between these. As mentioned in your Clark et al. Text, we may encounter clients who have suicidal thoughts on a daily basis, but have no intent to commit suicide. And we may have clients who engage in self-harm behaviors without suicidal intent. Working with survivors can be highly troubling for practitioners. We wonder what the right thing is to do, knowing that the stakes are very high. Acting or not acting can have serious repercussions. I have to remember to move the slides too. In order to effectively help our clients with suicide ideation, it's critical that we overcome the fear of talking about suicide. Although we might be thinking, if I don't know about it, I'm not responsible, or I don't want to put ideas into her head, the truth is that not knowing will not relieve you of responsibility for your client. And it's also true that asking about suicide will not cause your client to kill herself. So your best bet is to become good at having the conversation. Asking some key questions is important. So what wish is reflected in the suicidal statement? And what problem is solved by suicide? These questions provide information that helps separate the survivor's wish to die from the wish to be soothed or to lessen their pain. Asking questions like, what would it mean to be dead? And whether that is different from the wish to no longer be in pain makes it possible for us as clinicians to be direct and clear in our response. So in terms of assessing for suicide, we want to first look at, do they have any current suicidal thoughts? I.e., do they have a plan? Is the plan lethal? Do they have access to the means to kill themselves? Do they have a history of suicidal thoughts? If so, how long have they had these thoughts? What makes these thoughts more frequent? What makes them less frequent? Do they have a history of any suicide attempts, including details of lethality, the circumstances surrounding the previous attempts or attempts, what happened after the attempt, were they hospitalized, does anyone besides you now know about these attempts, what's their family history, is there suicide attempts in the family, what's the level of their current stressors, as well as current support. So we want to know who's available to help. Are they using alcohol or drugs? Do they have any psychotic symptoms? Specifically, are there any command hallucinations? So these are a voice or a visual message telling them to kill themselves. And do they have access to lethal means? Are they stockpiling medications? Do they have access to a firearm? What's going on there? To sort this out, there's sort of four main categories. So if your client has suicide ideation, they have a plan, and they have intent, they need to be hospitalized. That is a person that is likely to carry through. If they have the ideation, they have a plan, but they have no intent, it's possible to just do outpatient treatment and continue to assess them for suicide ideation. If they have the ideation but no plan and no intent, then outpatient treatment with continued monitoring is a good course to take. However, if they have the ideation and psychotic symptoms like those command hallucinations, then that would also be a case where that client would be better off being hospitalized. So in terms of just some general principles for working with clients around their suicide ideation, First of all, you want to be compassionate. So saying things like, I know you're in a lot of pain. Can you tell me more about your thoughts? It's really important to be open and non-judgmental. Questions like, does it feel as if it's never going to get any better? An open-ended question would be, how does this hopelessness affect your relationships? So anything that's inviting them to tell you more. Be direct. Don't hide behind euphemisms. Really explore with them what they're thinking, and use the actual language of, do you have a gun? What's your intent? Do you have a plan? Be really clear. Be relational. So refer to others in their lives. Questions like, what impact do you think committing suicide might have on your children? This is not to induce guilt in the client, but to ensure that they've really thought it through and they've thought about the entirety of the situation. And then just be clear about the limits of power and responsibility. Ultimately, it's not your choice. It's the survivor who ultimately chooses whether or not they're going to take their own lives, which is a hard thing, but is absolutely true. So in terms of safety concerns other than suicide, around self-harm, there are many. A person could be binge eating or purging or abusing substances, engaging in unusual or unsafe sexual practices, and then deliberate self-harm like cutting, banging, pinching, hitting, injurious masturbation, inserting objects in themselves, swallowing objects, hair pulling. The key mechanism linking these is dissociation. So a review in 2007 by Klonsky found that self-harm might be fulfilling a variety of functions for a survivor, including managing their negative affect or distressing arousal, which is the most common function, replacing the impulse to commit suicide, reinforcing the boundaries of self versus other, including others as kind of like a cry for help or affection, or to punish yourself, or to experience excitement or exhilaration. To basically take your mind away from the pain and to give you a different way to focus on it. And so although the self-harm might be serving a function, survivors do know that it's a taboo thing and often do it in secrecy and often with a lot of feelings of shame around that. So assessing self-harm, what do we do? First, you want to distinguish self-harm from suicidality. Next, you want to convey respectful curiosity. Questions like, well, what does self-injury do for you? You want to be calm, respectful, and dispassionate when you're asking those kinds of questions. Then you want to assess the details, including the age of onset of the self-harm behaviors, the duration of engagement in those behaviors, and the duration of each episode, the frequency of the episode, the methods they used, the kind of physical damage they've inflicted on themselves. If they know what triggered their self-harm. They could be psychological triggers like having certain thoughts and feelings. They could be behavioral triggers like certain habits and rituals that they have. And they could be environmental triggers like specific relationships or work setting or some other particular setting. And they could also be biological triggers like fatigue or insomnia or when they're ill or intoxication. We should also assess the social context of self-harm and any after effects, including short and long-term thoughts, feelings, behaviors, and interpersonal effects. Clark and colleagues suggest some do's and don'ts for working with self-harm. Do empathize with your client, showing concern for their body in a non-shaming way. Do promote understanding the function of the self-harm. This might help the client discover other ways to meet their needs. Do explore options to replace the self-harm behavior. Once the function of the self-harm has been identified, it becomes possible to explore different options, like making a symbolic act that doesn't harm them, or marking your skin rather than cutting it, or acting out the self-harm behavior with a toy, or distracting yourself with reading or walking or watching TV, or just delaying the self-harm by saying, I'm going to wait 5 or 10 minutes. Other strategies would be engaging personal contacts, like calling a friend or a support group member. Might also suggest the use of imagery, for example, imagining a safe place or other activity, engaging in some sort of tension-reducing activity like exercise, or knitting, or squeezing Play-Doh, anger expression activities like punching or throwing pillows or ripping up newspapers. There's grounding and reorienting activities. You could use a specific grounding technique, or maybe you could have your client look at pictures of their loved ones, or listen to music, or just lovingly touch their body with attention. Recommendations for things not to do are to take the self-harm behavior out of context. In other words, we need to stay focused on understanding what function the behavior is serving for the client. And we should not dismiss this behavior as merely attention-seeking. The survivor is really doing the best they can, and likely would make other choices if they could. Also, you do not want to hospitalize a survivor on the basis of non-lethal self-harm alone. This really takes power away from your client unnecessarily, and it can seem to the survivor as a form of punishment. And finally, do not make the cessation of the self-harming behavior part of a contract for treatment with your client. Rather, include alternative strategies for self-harm in the contract that you make with them, and ideas for what to do if the survivor self-harms. If a survivor starts self-harming in your presence, it's important to remain calm and share your observations with your client. I notice that you're pinching your skin. Invite the survivor into the present moment with you. You are here in my office. You are having a lot of feelings, but you are safe now. Use a specific grounding technique to assist in this process. And remember that if a client is doing this in your presence, that they are really trying to convey their distress to you. So it's probably good to remember that this is probably not the first time that they're doing this, and hence it's probably not an emergency. In terms of safety concerns and ongoing and current violence, asking, do you feel safe in your home, makes a lot of sense to those of us who work with survivors. However, it's important to know that universal screening is actually a controversial topic. The World Health Organization used to recommend universal screening for interpersonal violence, but they got some pushback about this because of a lack of evidence for its effectiveness. However, a dissenting opinion is that there's no proof that just asking actually does any harm, and that part of the reason why we're not seeing some traction from the universal screening is the fact that most providers are not knowledgeable about the signs and symptoms, and they're not standing ready to meet any disclosures of interpersonal violence with an adequate response. But the principles for responding to disclosures of current violence are similar to those that we discussed for listening to disclosures of trauma narratives, including building rapport, asking questions in a non-judgmental manner, communicating empathy, etc. One thing we for sure shouldn't do is ask a survivor why she doesn't just leave her abuser. For many, this is just not currently possible and will only cause shame on the part of your client. So we need to be mindful also that a survivor is actually most at risk when they leave or when they threaten to leave. So you could be, without adequate supports being in place, you could be inadvertently putting your client at more risk by suggesting that she leave before she's ready. So instead, we want to direct our efforts at providing support and information for next steps for the client. Work on a safety plan, what to do when there is threat. Assess the level of risk to her and her children, any children that she might have, and help link her to resources in the community. Our textbook alludes to a very nice online resource for responding to domestic violence in clinical settings, and I encourage you to check it out. as you can see here, it's dbeducation.ca/domesticviolence/welcome.php. Really great resources. It's important to remember that sexual abuse is not just something that happened in the past necessarily. Given that women ages 16 to 24 are particularly vulnerable, it's important to stand ready to respond to current sexual assault as well as clients who are reporting their history of childhood sexual abuse. So some basic things that you want to address are providing choice and offering back control, as much control as you can to the client in their situation. So those same principles of building rapport, asking questions in a non-judgmental manner, communicating empathy, etc., all of those things still apply. You want to give your client a choice about forensic testing if it's really immediately after the assault. That's really important to survivors. And you also might want to suggest that whether or not they choose to do forensic testing, that they might want to consider some prophylactic medication for any HIV exposure or other STI exposure that they've had, and certainly if pregnancy results as a result of the assault. Which brings us to mandated reporting. So New York State recognizes that certain professionals, and we are included in that, are especially equipped to fulfill the important role of mandated reporter. So we are required to report suspected child abuse or maltreatment when, in our professional capacity, we're presented with reasonable cause to suspect child abuse or maltreatment. This has actually been extended to include dependent all adults and elders too. And it's tricky because we want to, protect the confidentiality of our clients on the one hand, and yet we are mandated reporters on the other. This is underscored by looking at our NASW Code of Ethics. This commitment to our clients is part of our ethical responsibility. So we have that commitment to our clients, but as this says, we also have responsibility to larger society or specific legal obligations. An example is reporting when a client has abused a child or has threatened to harm self or others. So when we have, as we mentioned before about suicide, we have the suicide ideation plan and also an intent, but we also have lethality plan and intent. Those are reportable things. So we have to always bear that in mind. Now, does that mean someone that comes to see you who's talking about when they were abused as a 5-year-old, that you have a duty to report that to the authorities? Probably not, right? Unless your client drives that decision to make a case, right? So it's really more recent is what we're talking about here. And certainly ongoing abuse is something that we want to address. Okay, so I want to talk a little bit also in this module about transference and countertransference. So transference is when a client unconsciously transfers feelings they have about a significant person in their life onto the therapist. These are often based on early relationships and involve unconscious as well as conscious feelings. They can be quite powerful and overwhelming. Transference also allows the client to experience feelings that might otherwise be inaccessible. And by analyzing transference feelings, a client might gain some insight into the past. Unconscious attitudes that a therapist develops toward a client in response to client's behavior is known as countertransference. A countertransference feeling might interfere with the ability to be objective. However, it's not always detrimental to your therapeutic goals because it might provide an important means of understanding your client's world. We need to continually monitor our reactions to our clients so that we can use them to promote understanding of the therapeutic process. In other words, if we find ourselves being cast in the role of an abuser, say, and start feeling like an abuser in some way, that's important information and may in fact signify that we are caught in a traumatic reenactment. As Clark and colleagues put it, the survivor experiences the provider in a way that is similar to a traumatic aspect of a historic relationship, and the provider finds themselves pulled into a dynamic with the survivor that may feel out of proportion to the situation. Traumatic reenactment and countertransference, this is actually what brought me into this whole world of working with trauma and scholarship around trauma. I can share with you, back when I was working as a midwife, I was taking care of a woman who I had actually taken care of before for previous births, and I couldn't feel the baby's position. You want a baby to be head down preferably before they're born, and I couldn't feel for certain sure just from the outside that her baby was in fact in a head down or vertex presentation. So I asked her if it would be okay to do an internal vaginal exam to see if I could feel the head, the presenting part. And this is a woman, like I said, I had worked with her before and had actually done vaginal examinations with her before, and it had all gone fine. So she said that was okay. We started the exam, and suddenly she kind of went deer in the headlights and let out one of those attachment cries and became very upset. And of course, I stopped what I was doing immediately, and I gently tried to bring her back into the present moment. And thank goodness I had a good relationship with her, built over a number of years at that point. And so we were able to discuss this and really talk it through. And what came up for her was that in that moment, she was back being a 4-year-old girl who was being abused by her mother. And so I was being cast in the role of abuser, actually. And thank goodness we were able to talk this through. And what came up for her was that this was the first time she was pregnant with a girl. And that felt really different to her. Like that her little girl, which was her little girl, was more vulnerable than her boys had been. And that she felt like that sense of being invaded, that her little girl was at risk. And so it was just a really profound learning experience for me, and for her too, I think. I mean, we worked through it, and she had a great birth, and actually took on some therapy around that afterwards. But so these can be very profound exchanges. So I would encourage you, if this is ever happening in a therapeutic situation, to really use it as a tool for learning, and to be really transparent with your client about what you're seeing, what you're feeling, and to use those experiences. Along those lines, I think Karpman's triangle, this is a model from 1968, but I think it's still a useful model for conceptualizing reenactments with survivors. So any combination of the roles of persecutor, rescuer, or victim can be experienced by the therapeutic dyad of a client and therapist. Davies and Frawley added the idea of this neglectful bystander in 1994, and that's sort of standing in for that neglectful parent who maybe knew or suspected that the abuse was going on, but just stood by and didn't do anything to help. And when you talk to survivors, sometimes they have a whole lot more anger at that neglectful bystander than they do towards their abuser. But looking at these roles is something to be really embraced in the therapy room, provided the therapy is long-term and that trusting relationship has been established. So as for those different roles in the trauma reenactment, so if the client is in the role as a victim, they might be in that role, they might deny their feelings. They might feel like they have to be really good to maintain the relationship. They might feel like the therapist is really intentionally trying to hurt them, or that the therapist doesn't see them or doesn't really hear them. A therapist who's in that victim role might feel unwanted by the client, unhelpful, like they're working really hard to make a connection, but it's just not working, so they kind of feel like just giving up. A client who's in a perpetrator role in that dyad might intrude on the therapist's life, might make sort of very entitled demands of the therapist. They might threaten to terminate the therapeutic relationship. They might retaliate in some way for some perceived insults. A therapist that's in that perpetrator role might feel that they have to be really overactive and steadfast about not being similar to the client's abuser. And so they're being really hypervigilant, and then as a result they might erupt after weeks of being that way, of being dismissed or insulted by the survivor, and be really angry with the client. A client who's in this sort of rescuer role might become overly attuned to the therapist's moods and needs. In a way they're like trying to protect the therapist from the details of their own trauma. A therapist who's in that role as a rescuer, and that's, believe me, an easy role for a therapist to fall into, they might have the wish to bring that survivor home with them, to just try to protect them from having to have certain feelings. They might routinely extend the boundaries of the therapeutic relationship to try to accommodate the client. So that's how that could play out. A client who's in that bystander role might express like just boredom or be really irritated with the therapist for certain questions, or the therapist being interested in certain things. They might just sort of dismiss their own vulnerabilities as unimportant. A therapist in that bystander role might feel uninterested or bored by the client. They might start forgetting important details of the client's life. They might become unusually tired, just kind of watching the clock, yawning a lot. So, like I said, we can really use these enactments. We can use these roles to break free from these reenactments. So the therapist is the one that's going to have to facilitate the dyad from getting unstuck from these traumatic reenactments. So if you're in that perpetrator role, you're feeling in that perpetrator role, then you have to really work on developing your feelings of empathy. Work on understanding and validating the client's feelings, just to try to imagine yourself having the client's perceptions, and then try to put aside your defensiveness and not argue about the accuracy of their perceptions, but rather try to get more information from your client about what that really means. If you're in a victim role, lost a page here. If you're in a victim role, then you need to recognize that you're feeling victimized. That feeling victimized is an important part of understanding the client's experience, right? That's like one of the core things. So, but given that, you really need to put some limits on what the survivor does or says that are overtly abusive, right? You can't allow the client to abuse you in the process. And then you want to share your experience of feeling like a victim with the client to really help them understand this dynamic. If you are in a rescuer role, then you want to kind of put the brakes on and stop and wait and acknowledge that you have this urge to try to protect the client or give them special treatment. But at the same time, you want to support the survivor to feel empowered to face their own struggles and heal. And you want to ask yourself whether this dynamic is reminiscent of other dynamics in therapeutic settings, and ask that same question of your client. You know, what does this remind you of, this relationship? What just happened in our relationship here? Does it remind you of previous relationships? And then just helping the survivor explore what they can do to help themselves when they're feeling that way. If you are in a neglectful bystander role, yawning in the therapy role, then you might want to try to flip the switch in your brain to become the mindful or wise observer. So acknowledge that you're having these thoughts and feelings. I'm feeling bored, I'm feeling out of touch, disinterested, and then stop and ask the survivor about their experience in that moment so that you can kind of reveal this dynamic a little bit and really engage the survivor in exploring that dynamic. What's going on there? And then once you've done that, then you can actually work together to make conscious choices based on now and see that this dynamic is really mirroring a previous dynamic, but we can make a different choice going forward. Okay, so I want to shift to talking about vicarious traumatization for a little bit. So vicarious traumatization can affect both our professional and personal lives, and it's really important to address. Listening to trauma narratives can lead to a variety of symptoms very similar to those experienced by the client themselves. The list is long and includes many indicators, but basically look at all the PTSD symptoms, depression, fatigue, all the bodily symptoms, right on down the line. We can experience those in reaction to other people's trauma just as we can experience it from our own trauma. There are some tools out there that are available to do some self-assessment about your level of vicarious trauma and your reactions to it. You can use a list like the one that's in our textbook to self-assess. That will be a good place to start. You can talk regularly with colleagues and seek continuing education about vicarious trauma. You could consider using a tool like the ProQ-Qual 5 to assess compassion fatigue, burnout, and compassion satisfaction, and I provided you a link to that tool. But in terms of just basic strategies for addressing vicarious traumatization, first and number one, we want to practice self-care, including setting limits or boundaries around trauma work, striving for that work-life balance, engaging in healthy habits, ensuring your connection with others, engaging in whatever nurturing activities work for you, and occasionally escaping into fantasy and play. So we also want to address the loss of hope and demoralization that we might feel. And so the way to do that is to engage in activities that are infused with meaning and creativity. And that includes engaging with others specifically around this issue, seeking supervision to vent and to explore new pathways for dealing with the fallout of a trauma. And it also needs to be addressed at the organizational level, meaning that whoever you work, there needs to be adequate supervision, including also creating a trauma-informed climate that provides a safe setting for expressing your strong feelings, offering health benefits that include mental health services if you find yourself really needing that. And also you would love to have your agency explicitly acknowledge the hard work that clinicians do. And one really concrete way of acknowledging that would be to have staffing patterns that allow adequate backup and sharing clinical responsibilities and adequate coverage so you're not overburdened, right? And affirming the effects of interpersonal trauma, helping staff to address and to identify and address signs of vicarious trauma. And then, like I said, providing opportunities for continuing education. All of these things can help address vicarious trauma. I like this graphic from the assigned Cohen and Collins 2003 meta-synthesis of the literature because it's not only about vicarious trauma, but also vicarious post-traumatic growth. They found overall that the impact of trauma work can potentially increase short and long-term levels of distress, and that such psychological impact can be managed through personal and organizational coping strategies. It also highlighted that distress does not necessarily preclude growth, especially when you look at the pathways in the graphic that extend from the amazing privilege of witnessing our clients' growth and the amazing leaps they can make and how they can enter into their own post-traumatic growth work, leading to changes in their schemas and day-to-day routines, and that these changes can be both negative and positive. And so this implies a sort of non-binary view of the impact of trauma work. It's a complicated story. the changes this schematic depicts corresponds to both vicarious trauma and vicarious post-traumatic growth. But in order for vicarious post-traumatic growth to occur, trauma workers will need to be exposed to the client's own growth. So they're basically here making a case for hanging in there with your clients in the long term, right? And resting into coping and institutional and other support systems to sustain ourselves in order to be able to hang in the long term. And that if we do that, that investment can really reap benefits, not only for our clients, but also for ourselves. So I think that's a very powerful message and really speaks to what we do in an ideal way. One last note regarding organizational support and its importance. That Tripani et al. Article that we read from 2004 outlines many specific ways to prevent vicarious trauma. These include addressing our own needs for safety, self-esteem, intimacy, spirituality, and control. Our organizations can support us by ensuring that we have adequate supervision, appropriate caseloads, opportunities for consultation and education, and trauma-specific training. These are the types of supports we should be looking for when we're job seeking. So just to recap, we need to overcome our fear of talking about suicidality and interpersonal violence and develop strategies for assessing both of those and for discussing those things in a really frank and clear way. Similarly, we need to address self-harm behaviors with a spirit of respectful curiosity. It's important to know that we can use transference and countertransference role awareness to break out of patterns of traumatic reenactments. And then finally, preventing vicarious traumatization effects is possible, and it's clearly very important. So